Hi, and welcome to AAHPO's American Armenian Health Professional Organization's TV Health Program. Today's topic is prostate cancer, which is one of the most common cancer among men. And recently there are controversies about screening and the treatment of prostate cancer. To discuss this common disease among men, we have invited Dr. Erol E Ulker-Sarokhan, who is board certified in urology and in private practice in Essex County. Dr. Sarokhan, welcome to our program.
Thank you very much for inviting me.
So prostate cancer is one of the most common cancer among men, and there are some certain controversies lately about screening and the treatment of prostate cancer. What should we do in terms of prostate cancer and screening?
Okay, yes, prostate cancer is a very common disease of men. We predict 1 out of 10 men will have prostate cancer. The newest thing now is that men of white race, it should be screened or it should be checked at the age of 45 to 50 if they have any family history of prostate cancer.
How about African Americans?
African Americans, they have much higher incidence, therefore they should start at age 40.
40, how about if they have family history?
Right, if they have family history of prostate cancer, very close relatives such as father, brother, uncle, then they should start at age 40 as well in white man.
So the screening is with the PSA, which prostate-specific antigen, what we call, and digital rectal, DRG, this is DRE, digital rectal exam. What do you do in your practice when they come to see you? Let's say I see my patient and I have suspicions of they might have a prostate cancer. I'm sending it to you.
We check their PSA and the digital rectal exam, like you mentioned before. The PSA exam is actually age-related. So, if somebody is younger age, the PSA number should be low. When somebody is a little bit aged, it should be higher.
What's the normal number for PSA?
Right. As on average, in most of the laboratories, they count as 0 to 4 being a normal level. Right. But if somebody is like age 40, 45, 50, it should be not more than 2.5.
Age, is that is a
age, very age-related. But somebody who is in their 80s, 90s, actually, they don't need to be screened for sure. Right. But if they're 60s, 70s, actually 70s, even 5.5 might be a normal number.
Recently they were saying that if you screen for PSA and it's high, too many of biopsies are being done, so that's why there's a little controversy. Should we do the PSA?
There's a lot of controversy about this, and you hear this in the literature, in the newspapers, but I'm going to tell you what my belief is in this and our consensus. Right. I think that patients should be screened for prostate cancer because in the last 15 years that they've been screened, we have saved a lot of lives. And this has been proven. The numbers are out there, so there's no excuse not to do that. It's a very simple test, and yes, there is definitely some overtreatment, and in this case, however, if we can save a lot of lives through that, right, I think let it be. But we have to also use our judgment, in this screening process. Like I mentioned before, if somebody is an older age, they don't need to be screened.
I know PSA is in one way of screening, but digital rectal exam, DRE, is more important possibly when patients come to you, and probably you might be diagnosing some patients with just rectal examination and then PSA itself.
Yes, very, very good point. There are a lot of actually famous people who were diagnosed with rectal exam, digital exam. They found nodule and their PSA number were actually less than 3. One of them was 1.5 and had a prostate cancer. In my practice too, I do get to see quite a few of those type of cases. So therefore, these two go hand in hand.
Right. So PSA is not alone. We have to do PSA plus the rectal examination really to confirm the diagnosis, yes, in a way, or start the treatment.
Yes. Or either one of them, could raise a red flag.
Let's say that you found a firm lesion or firmness in the prostate. What the patient is going to go through now? Let's go them through the process.
So, either if they have an abnormal rectal exam, let's say, and prostate nodule, or their PSA number is high, right, then the next step will be to do a biopsy with prostate ultrasound at the same time. And we do that in our office setting, right, under local anesthesia.
Right. So now, under the ultrasound guidance, that kind of
exactly.
Biopsies.
Yeah, the ultrasound test is not very specific to pick up a prostate cancer. Right. It's still a very gray zone, but it helps us to be able to detect or to place needle in different parts of the prostate. Right. Therefore, when we do a random biopsies, we know that we're getting biopsies from different parts of prostate. And so it's a random biopsy process, unless I know that the patient had a nodule on the one side or one area of prostate, then I can focus on that. That will show on the ultrasound, and I can get specifically from that area.
Is there any MRI? MRI has any place in the prostate cancer screening?
Yes, the MRI concept has changed from day to day. Before it was very important, and then one time it became not that important. But now there is a new type of MRI that is very, very specific for the prostate. And in the cases when we have a patient who we suspect prostate cancer, but we do biopsies, it comes back negative, then with the MRI guidance, we can do rebiopsy that area only, and our results are much better now.
Much better now. Okay. So one thing is very confusing to people. I think you can explain that to our audiences, that benign prostate hypertrophy has nothing to do with the prostate cancer, or can be with the prostate cancer. On the other hand, you can have a normal prostate size with the prostate cancer. So let's talk about benign prostate hypertrophy, the process of it, and the prostate cancer, where they go together.
Right. So actually there are three subjects in this matter. One is prostate cancer, obviously the one that we are most concerned, but then also there's a big area of benign prostatic hyperplasia, which is the benign disease of prostate, which is much more common
which comes with age anyway.
With aging, most of the time. And there's also prostate inflammation, which is also very common in the prostate.
It's called prostatitis.
Prostatitis, but it could be also very, very asymptomatic, or a kind of an inflammation that does not show any symptoms whatsoever.
Right.
So the benign prostatic hyperplasia is very common, but it doesn't really go by the size. You can have a large prostate, but you will not have any symptoms at all, because it will not be causing any blockage of your channel where you urinate.
Outside of the prostate itself, not necessarily in the channel.
Exactly. So therefore, when we want to treat somebody for prostate enlargement, we don't go just by the enlargement, but go by their symptoms and their findings on the studies.
Right. They can have even smaller prostate, but if the channel is closed, if they have symptoms, then they might need it.
Right. They can have a small but very fibrotic prostate that can cause obstruction of that channel.
Right. Sometimes we have elevated prostate PSA level, actually, and then we are suspicious of, at the same time, prostatitis. So we give an antibiotic, and when we should repeat the PSA level, possibly after antibiotics. What's in your
right? Now, if somebody has actually symptoms of prostatitis,
yes,
they should definitely be treated with antibiotic for at least a month, and then recheck the PSA if you're suspecting that. But if you're just thinking about maybe this person has a prostatitis without any symptoms, the studies have shown that by treating with antibiotics, repeating that PSA does not really help that much. Only if they're symptomatic, if they have signs and symptoms of prostatitis, should be treated.
Dr. Sarokhan, now let's talk about the advanced disease. We have the prostate cancer now. It's not localized and it's spread, the advanced disease. What do we do?
Okay, so actually I'm going to just go back a little bit when you asked me about once somebody has a nodule or an abnormal rectal exam or high PSA, what's the process of trying to find out the cancer? So let's say we did the biopsy, we found the prostate cancer, then we look at the pathology report. And there are certain parameters in the pathology report that tells us the aggressiveness of the disease, such as Gleason score,
that we are talking about,
and what percentage of the core of the biopsy are involved. And also the PSA number comes into play. As a matter of fact, there's a table where you can put the PSA number and the Gleason score in there together and the patient's age, and you can get an idea of the prognosis of this patient. Right. So let's say the patient has a localized disease, meaning that the cancer is only inside the prostate, has not gone outside the prostate.
And then we can do a CAT scan actually to find out
right.
if they have...
Well, actually, the whole policy have changed these days. Right. If somebody has a PSA of less than 20
yes,
and has Gleason score is less than 7,
right,
they don't require to have any bone scan or CAT scan done. That's all out
so there's
now.
A number there we can go by.
Right, because the studies have shown that there's nobody in those numbers have any findings.
Right.
So therefore, if somebody has a localized disease,
right,
then we're going to go for cure. Now, at this point, it also depends upon how much involvement was the disease.
And plus the age group, I'm
exactly. But let's say he's in like in his 60s, right, and also his number was very, very low.
Yes.
Now, in a case like that, sometimes we can just watch it, actually. There's such a thing as watchful waiting, observation. Right. But this person has to be monitored very, very closely to make sure he doesn't get any aggressiveness later on. But if they have a medium type of disease, but it's localized, then we talk about a couple of options. One of the most important option is to do surgery in a young age.
Right.
We consider young age up to at least 65.
Which we are talking about total prostatectomy.
Right, which is a radical prostate, taking the whole prostate out. Right. These days we do it with a robot, and it's a very less hospital stay and less complications and very, very quick recuperation. Okay. Okay, that's one option. Second option is to give radiation treatments.
Right.
Radiation treatments could be many different ways. There's a cyber knife, there's proton therapy, and there's a regular radiation therapy.
Right.
And these are also done in a very minimum toxicity ways these days.
And one of these radiation is chosen because of the patient age and the disease process?
Well, you know, the most common ones is radiation, external beam radiation therapy.
Yeah.
The other ones are a little bit more, they're not as much available, but they're kind of a little, to me, it's like a little bit of gimmick.
Gimmick, okay.
And they might take less time to treat somebody, but their results are not that, that available yet for the long-term
But
results.
if the age is higher, let's say somebody's 75 and above,
Right.
then surgery might not be in the picture as much as the radiation.
Right,
is.
definitely somebody in that age group definitely will go for radiation treatments.
If somebody's 80 years old, what would
Right.
you do?
Well, first of all, if somebody's 80 years old, they should not, if they have no symptoms of any bone pain or any other symptoms, they should not have any screening tests at all.
Okay.
Okay, that's the newest thing. And if they do have it, once they have the screening test done, then if their number is very high, then you're obliged to do a biopsy and see if they have a cancer or not. Then you sit down, talk with the family. In that case, they could be treated with hormones. Okay, and
What the hormones, that's what I was coming through.
Right.
So there's somebody old age, they have the disease, even if it might be progress, we have the treatment still.
right. I mean, if they are 80 but very good shape, they can still have radiation treatments, very benign. But if they don't want that or they're sick, there are a lot of more comorbidities, then they can go ahead and have the hormonal therapy done, which will kind of arrest the disease for some time.
Dr. Erol E-Ulker-Sarokhan, thank you very much for the enlightening information. Hopefully we'll see you in another program.
Thank you very much for inviting me.
Now it's time for this week's article. It is processed red meat consumption and hypertension in women. Red meat is a rich source of zinc and dietary fiber. Total meat consumption is usually classified between processed red meat like cold cuts and hot dogs and fresh unprocessed red meat. Processed red meat like cold cuts and hot dogs contain nitrates as preservatives. High consumption of these processed red meats are associated with increased risk of various chronic diseases such as type 2 diabetes, heart disease, and some cancers. In recent years, many studies have also documented an association between red meat consumption and mortality for all causes. This association is partly explained by the negative effect of processed red meat like hot dogs and cold cuts. No association was found with fresh, unprocessed red meat. A study from Sweden showed that consumption of processed red meat was associated with progressively shorter survival. Study from Harvard School of Public Health evaluated relation between consumption of unprocessed red meat and incidence of high blood pressure. In more than 40,000 women, they found an association between consumption of processed red meat like cold cuts and hot dogs and hypertension, and no association was found with unprocessed red meat. In conclusion, in order to decrease the chance of getting chronic diseases like diabetes, heart disease, high blood pressure, and some cancers, stay away from processed red meats like cold cuts and hot dogs, and have 1 or 2 days a week unprocessed fresh red meat for its protein and zinc content. Good health is precious and priceless. Stay informed. Don't forget to visit AAHPO's website for up-to-date medical information. I'm Dr. Orhan Karatoprak. Until next program, so long.
Անցյալ կիրակի հայ առաքելական եկեղեցին նշեց տարվա 5 տաղավար տոներից երրորդը, Քրիստոսի պայծառակերպության տոնը, Վարդավառը, որը Մատթեոս ավետարանիչը այսպես է նկարագրում. Նրա դեմքը փայլեց ինչպես արեգակը, նրա հագուստները դարձան ճերմակ ինչպես լույսը։ Պայծառակերպությամբ Քրիստոսը ցույց տվեց իր աստվածային էությունը։ Այդ օրը եկեղեցին իր հավատացյալ զավակների վրա Սուրբ Մեռոնով ջուր է ցողում։ Այս տոնը հայ եկեղեցում փոխանցվել է դեռ հեթանոսական ժամանակներից, երբ Վարդավառի տոնը կապված էր ջրի, սիրո, պտղաբերության եւ գեղեցկության աստվածուհի Աստղիկի հետ։ Այս տոնին միմյանց վրա ջուր էին ցողում։ Քրիստոնեական շրջանին ավելացել են նաեւ համբարձման արարողություններ, օրինակ վիճակահանությունը։ Վարդավառին սովորաբար եկեղեցուն նվիրաբերում են հասկեր եւ խնդրում, որ բերքը առատ լինի։ Տարին ջրառատ կազմակերպում են խնջույքներ, տոնակատարություններ։ Վերջին տարիներին Եղարդում եւ Գառնիում տեղի են ունենում նաեւ Վարդավառի փառատոներ։ Վարդավառի տոնը այժմ նշում են նաեւ Հայաստանից դուրս Մոսկվայում, հայկական եկեղեցվով հովանավորությամբ, ռուսական այլ հայաշարք քաղաքներում։ Իսկ Երևանում մինչև ուշ գիշեր չի դադարում ժողովրդի լեզվով ասած ջրոցին։ Այսքանը սիրելի բարեկամներ, մինչ ձեզ հրաժեշտ տալ, ուզում եմ մեկ անգամ եւս հիշեցնել, որ այս մեր բոլոր հաղորդումները դուք կարող եք դիտել on-line Սփյուռքի ձայնի նոր ընդարձակ վեբսայթում, ինչպես նաև YouTube, Facebook, Vimeo, Twitter ցանցերում։ Կապ հաստատեք մեզ հետ, լայք արեք, գրեք ձեր առաջարկները, ձեր կարծիքները։ Մեր հաղորդումները զետեղված on-line յուրատեսակ արխիվ են մեր սփյուռքահայության կյանքի մասին, Նյու Յորքի հայության կյանքի մասին, այսինքն ձեր մասին։ Եվ այսպես ուզում եմ ձեզ հրաժեշտ տալ, ինչպես միշտ ցանկանալով հանգիստ եւ արդյունավետ շաբաթ։ Մնացեք բարով, մինչ նոր հանդիպում։